Thank you very, very much. I'm actually not representing the North American perspective. I'm actually representing the Pan-American perspective, and I'll give you a little bit of background into that. When Willem suggested the idea of an intercontinental debate, it certainly was very, very intriguing, and there are many aspects to the evolution of ultrasound in the hand of neonatologists over the past number of years. But one of the most interesting aspects is you have an Irish person representing the Americas. You have someone of multinationalities, I'm not quite sure which is his allegiance of choice, representing Europe. And we have an Englishman representing Australasia and New Zealand. Now, if you look very closely, Dr. El-Kafash seems to be hiding something. And what he's hiding? Well, he's hiding the new continent of Brexit, which is going to be represented by an Indian. So the world has changed very dramatically. So, Willem, I'm going to put it down to you. You have now declared the new continent of Brexit. So, congratulations. I have to say a word. I thought I was going to go first, but I actually suggested to Willem that Nick should go first, because at the end of the day, we would not be here today were not for Nick. He is the pioneer in the field. He is the person who took the mantle of this, and certainly was the person who inspired us all to actually take out this equipment and to look at our patients in a much more thoughtful manner. We're in Italy, so I can't go without showing this 1994 World Cup. Not every great thing has originated from England. It's not just Nick Evans, but also the game of football. But is it soccer or is it football? Okay, in Ireland, we actually call it soccer. In Canada and North America, we call it soccer. In England, we call it football. But to be honest, it's just a name. And it's more important than just a name. If you actually look at the history of football, over the last 150 years, the game has changed tremendously. So here you can see 1860 in England, you can see what was important. Offense was important. Defense, no one worried too much about. The game has transitioned significantly, and obviously the vast majority of formations that have won the World Cup have been defensive-minded formations. The ball has changed. And in many ways, this parallels the evolution of ultrasound from a tool that was very much a tool in which you had to take the patient to a piece of equipment, to a bedside piece of equipment that's available now for us all. Programs evolve. Progression is good. Optimal care is our mandate. At the end of the day, whatever we do, whatever the tool that we use, we need to bring it back to patient care. So what's the fuss? Well, is it the name or is it the game? And I would argue it's the game. And the two fundamental issues, and I think that have been pointed out already, how long should training be? Should we train everyone, or we should train experts? And the answer to this question perhaps rests in where you are and how your program needs to evolve. So I'm going to start off with a very brief case. It happened about 6 months ago. A term baby at Sick Kids, born with perinatal hypoxia ischemia. Baby had a blood gas of 6.9, low Apgars. The baby underwent therapeutic hypothermia. The clinical picture was a little bit odd. Baby had a pre-post ductal oxygen saturation difference of up to 20% and was being given oxygen and ended up getting intubated. Here's the course. The baby started to develop falling systolic blood pressure, was started on dobutamine. And at that point in time, the clinician came to me and said, well, we have this baby. We think you guys should probably come and scan the baby, but the baby's got PPHN. I'm just going to give him nitric oxide. I think everything will be okay. So the baby was started on nitric oxide, but became sicker. His blood pressure continued to fall. The baby's lactate increased further. So we scanned the baby. Here you can see this is a 4-chamber view of the heart. You can see that the right ventricle is profoundly hypokinetic. Not a big surprise. Babies with pulmonary hypertension in the face of high afterload are at risk of RV dysfunction. When you go and look at the measurements, and when we assess the right heart, we do fairly comprehensive assessment. The TAPC, which you heard from Eric, incredibly low. fractional area change was low, and tissue Doppler and strain analysis were also low. So severe RV dysfunction. One may think, okay, maybe we need to give a different inotrope, support the right ventricle better, we're on nitric oxide, and you could stop at that point. But I think Nick has pointed out it's important that we are comprehensive, and at the heart of targeted neonatal echo, or whatever you want to call it, comprehensiveness, not just in terms of anatomy, but also in terms of physiologic thinking, is important. So as we went through the scan, we actually identified that the baby, in addition to a dysfunctional right ventricle, had a coarctation of the aorta. You can see here on the left-hand side, you have an area of narrowing with post-ductal or post-ballooning, and you can see the turbulence here. Baby's flow across the ductus was predominantly right to left. The flow across the VSD was predominantly left to right. So we confirmed our diagnosis. So this is a scan performed by the neonatologist with full anatomic review, and we confirmed then later with our cardiologist in our program. We do the scans, we do the sweeps, and they can see the images whenever they like, if we need them to see them. So we stopped the nitric oxide. We focused on targeting the preductal stats of over 85, transitioned the baby to epinephrine, started the baby on prostaglandin. Within 1 hour, the baby's blood pressure had improved, the baby had weaned to room air, and his lactate had normalized. So why present the case? Well, here you have a complex physiologic situation. You have a baby who's been asphyxiated, who's at risk of impairment in heart function, but you have various modulators going on. You have coarctation, and you have a patient who is actively being cooled, which is driving up his systemic vascular resistance. So now you have to manage a baby both from a congenital heart disease, but also from a perinatal hypoxic ischemia perspective. We maintained the cooling because obviously protecting the brain was important. We didn't need to change the target temperature, but the focus of care was in supporting the right ventricle and maintaining this right to left shunt to support both pre- and post-ductal perfusion. So why present the case? Well, okay, my Achilles heel. Okay, I have to put this up here because I'm representing the Americas, and unfortunately this gentleman here doesn't do our service very well. If you look through the analogy, why do Donald Trump and a turtle on a post what do they have in common? You know he didn't get there by himself. He doesn't belong up there. He has no idea what to do that now he is up there, and so forth. So my Achilles heel. However, I must point out, I am not American. I actually come from the land of saints and scholars. And if you actually look at the history of the world, the Irish have played a very important part in saving civilization. So, you know, the voice of the Irish, as the great Conor McGregor says, the Irish speak the truth, whether you like it or not. But I have to say, you have to be very wary of the masquerading Irishmen seeking to represent Europe. And I know in Ireland we didn't have too many Elkafashas in my class in school in the west of Ireland, so just a point of caution. We talked about the guidelines. It's interesting. I'm representing the North American guidelines, but actually the T and Echo guidelines were not developed by North Americans. They were developed by a consensus of North American neonatologists and cardiologists from both Europe as well. And actually 70% of the people on the guidelines were actually European. They were not they were not North Americans. Actually, interesting, the American flag somehow is just vanishing from this. And it's not intentional, Phil. We're just not trying to wipe you guys off the map. However, in saying that, you must recognize that there have been many great things have originated in the United States of America. The light bulb, the car, kind of air flight, Disney, and so forth and so forth. However, it's important to recognize that the roots of the United States are actually in Ireland. So at the end of the day, as they say, these are the hands that built America. The Irish are at the forefront of everything. So the term targeted neonatal echo, and I'm not going to go into details here, and we actually are kind of using this less and less because it's actually hiding the real issue. Our concerns, and they're not really concerns, but this is not just about imaging. Okay? Actually, what's interesting and what's more important is we're actually performing hemodynamic consultations in which comprehensive echo examinations or ultrasound examinations, because our assessments are not confined to the heart, are actually part of a much more comprehensive thinking process. And our mantra really is an optimization of patient care, enhanced precision of monitoring, enhanced choice of therapies, so that our outcomes are good for our patients. And the mantra of our program is the right therapy for the right patient at the right time, independent of the organ. So why do we believe that the training should be longer? We believe that the training should be longer because to get to the point of expertise, it's not just about can you take pictures. I can take anybody from the street today and we can take them to take the pictures. Anybody. But then we're generating an ecotech model. The beauty of the enhanced training is immersing people in physiology, immersing people in pathology, getting them to have a much higher level of understanding of pharmacotherapeutics. And this takes time. Even after 300 consultations and 1 year of training, people still sometimes don't get it right. It's not easy. It is complex in certain situations. And the curveball in particular is a problem. Nick has already pointed this out. I'm not going to labor the point. Imaging of whatever the organ, you need to have a level of competence. But the more important piece is the interpretation. In my career, I've seen people make mistakes because they dissociate what they see on the ultrasound assessment from what's going on with the patient. And they start blindly following numbers, new numbers, that are not very helpful. So, a point of caution. Everybody believes that the T and echo guidelines are driven by cardiology, and in practice that's not the case. Okay? Our program in Toronto is exclusively led by neonatology. Okay? Both the training and the clinical application of the process are driven by neonatology. But the program has evolved to a level of complexity that with standardization of imaging assessments, with a comprehensive training program, we have a very integrated model in which our clinical care, our education initiatives, and our academic output are all interrelated. And teaching is driving clinical care, which is driving research, and you get this beautiful academic model. And certainly in North America, we would not have been able to move from 2005, when there was just people like myself and Shahab, to where we are today with a growing program, were it not for these guidelines. And that's important to recognize, that to move the North Agenda model forward, this had to happen. In terms of the training, Nick has pointed out the aspects of CCPU. Our training shortly also is going to be accredited. We've applied to the Royal College of Physicians and Surgeons of Canada, and our 1 year of training will be endorsed as an area of focus competency with a similar structure to what exists in Australia. But key to the model really is this immersing people in physiology and exposing them. During their 1 year of training, our trainees will be exposed to somewhere between 300 and 500 clinical consultations. So the level of expertise increases, and these individuals can go out into any center anywhere in the Americas and learn to build a program, and to build a program that's good and that's strong. However, in saying that, none of us here today can stand and say, you must do X number of scans to be competent. We actually have no idea. There's no educational science in neonatology. There's a little bit in adult cardiology, but not very much. So what's the rationale for the Pan-American approach? Well, we're not dealing with a simple problem like the case presented, and there are many, many other cases. We can make mistakes. Maintenance of competency. If you train everybody, how do they maintain competency? How do they maintain competency in looking after very sick babies? That's a challenge we have in neonatology, and how to maintain competency in intubation, for example, and other skills. The academic potential, I think, is the real strength of the model. And if we think about the last 30 years within our current approach, we really haven't evolved very far with the measurements we've used. We're confused. The best example is the ductus. 40 years of wandering. You heard me talk about that yesterday. rooted in lack of defining the population of interest and designing trials that don't answer the question you want. I think we're going in the right direction now. We're not dealing with a simple problem. It's complex. Our goal is optimization of cellular metabolism and tissue oxygenation. And the reason you may have disturbed cellular metabolism may range from your hemoglobin to the complexities of cardiovascular physiology to lung physiology, and it requires people to take the time. When we see our patients, we see them, it takes 45 minutes to an hour to do their clinical plus echo assessment, and then there's another hour of discussing the case, which leads to an academic discussion and a clinical recommendation. For example, just an example, the baby who's not responding to nitric oxide may require further manipulation of pulmonary vascular resistance with alternative vasodilators, may require optimization of right ventricular function or opening the duct, may require manipulation of flow across the ductus by agents which will have vasopressor effects without compromising pulmonary vascular resistance. To further exemplify the point, Reagan, who's sitting here in the front row, did a very nice study a couple of years ago when we actually looked at a large cohort of scans that were done over a period of a year, and we asked the neonatologist to put down what they thought was the clinical diagnosis. And we then went on, we did a scan, and 6 months later we then compared what was in their sealed envelope versus what was the actual diagnosis. And what we found was that in critically ill babies, the degree of concordance may be up to 93%. So we may think what's going on clinically, but oftentimes it may not be correct. How reliable are our methods of assessment? Yesterday we talked about the variability in ductal parameters. However, how reliable is heart function assessment? The vast majority of people assess heart function by the human eye. And that's a function of how good are you at looking at images and how good is your eyesight. And as you get older, your eyesight deteriorates. We actually looked at this in a cohort of 60 patients in whom we took experts and we got them to look at 6 to 7 images from healthy patients and from sick babies with PPHN. And we asked them 3 questions. Is the heart functioning normally? Is the heart dilated? And is the septum flat? And what you can see is that the kappa coefficients for this are horrible. So subjective assessment has its limitations, and we need to evolve to a level of sophistication that helps us to actually appraise our patients better. How do we deal with this? Competence of training, integrating the information in a holistic manner, and performing assessments that are comprehensive. One of the benefits of the collaboration is we learn new techniques. We learn better ways to assess the right heart. And Phil is going to come probably and talk about some of these techniques later on. But the future is in understanding better things like heart function, and this hopefully will help us better provide care for our patients. One example here, some data recently, this manuscript's under review. TAPSI in babies with acute pulmonary hypertension less than 6 have a much higher incidence of death or need for ECMO. How you modify RV function and its impact on these outcomes, still to be known, but these additional markers of right heart function may give us better insights into how well our patients really are. So, just for the last couple of minutes, if you give me some time, one of the things that's thrown is that our program will limit progression. It'll stop because the training is too long. And it's not that long ago, 2005, it was just myself in Toronto as the only individual in Canada. The first start was building the group in Toronto. And between 2009 and 2014, there were 6 academic neonatologists who had a very specific different areas of academic focus who collaborate together. So you build this strong academic developmental hemodynamics group. You see a familiar face in here, Dr. El-Kafash, okay? However, be wary of the masquerading Irishman. Started off at Mount Sinai, moved to Sunnybrook Hospital, and, we had some issues with him, so we actually kind of sent him on his way back to Europe. So we'll see how he's doing there. The program is built on academically to understand cardiovascular physiology. We need to define normality, appraise the reliability of our techniques, define mechanisms of disease, understand predictive models, and based on predictive models, develop intelligent pharmacological studies of relevant therapy. From just me and the Toronto group, we now have programs all across Canada. We have Trans-Canada webinars. We have collaborative research studies going on across the sites. As mentioned, we now have our area of focus competency, which will be approved to provide a political endorsement for the training. And that collaboration has actually now extended to our colleagues south of the border, with representatives from South America, with representatives from Mexico. So the membership is growing, and this certainly will enhance the development of the field in North America, or in the Americas. So my last word, I think there's room for everyone. There's no one size that fits all. I think there's a room for many different types of programs. I think the academic program in neonatology is imperative if we're to develop scientifically. Structure depends on regions and countries. I think one of the other unintended ripple effects of our program has been reinvigoration of the concept of the intensivist. Neonatology has been moving away and away and away from the intensivist model to a very hands-off approach, and whilst that's good, that's not good for everyone. And if you've got problems, you need to fix them. And I believe we're moving to a point that within regions, I think we will have a hybrid model of experts and novices all performing some degree of ultrasound. But my final words to you today, be thoughtful, be aware of your limitations, always second guess yourself, be introspective, and most importantly, when you have these skills, be humble. Thank you very much.